Everybody, sorry that we were a little late today. Had a few technical difficulties. You know how that goes. The blessing of technology and the curse of technology. It's wonderful when it works and drives you crazy when it doesn't. So today I have with me Dr. Jerry Reed, and Dr. Reed serves as the Senior Vice President for Practice Leadership at the Education Development Center. And in this capacity, he directs the Suicide, Violence, and Injury Prevention portfolio and leads a staff of 53. So just to unpack that a little bit for you, he oversees the work on multiple projects such as the Suicide Prevention Resource Center, the Zero Suicide Institute, the Action Alliance for Suicide Prevention, where I met him, the Children's Safety Network, several violence prevention initiatives, and serves as the co-director of the Injury Control Research Center for Suicide Prevention with partners at the University of Rochester Medical Center. And I'm smiling because I left off a couple of pages, I mean, how do you even have time to eat, sleep, and play? That is a very busy, busy life.
And very fulfilling one as well.
Yeah. So welcome. I'm so glad. We met about 3 or 4 years ago when I was asked to participate in the Action Alliance of Suicide Prevention, and just knew instantly that Dr. Reed is a compassionate man. He has a passion for preventing suicide, for helping people come to that place of wholeness and wellness where suicide is not a part of their daily lives or their thoughts. So we really connected over that, and it's just a privilege to have you with us today. One of the things that has been through these years since my son Matthew passed away has been an increased understanding of how suicide affects men in particular. And we've got lots of statistics about it, probably share some of those even of how suicide affects men. But I read in 2013, soon after Matthew died, the national strategy, the U.S. national strategy for suicide prevention. And I've told you how impactful that was for me, and what a strange thing that might seem for a grieving mother to read. But I was so comforted to know that there were such good people working in intelligent ways to effectively reduce the number of people whose lives were affected by suicide. And so if you would just maybe give us, we'll talk about men and suicide specifically, but just tell us right now a brief overview of the work that you do, the national strategy, and how that's trying to be implemented in our country.
Well, thank you, Kay, and thank you for having me this afternoon. It's a real pleasure, and I've enjoyed knowing you for the years that we have had the pleasure of working together. I came into the field about 20 years ago, quite by accident, the field of suicide prevention, when I worked on Capitol Hill for a U.S. Senator. And one day during a hearing on mental health in the elderly, it was revealed that the older adult community had one of the highest rates of suicide in the nation. I did not know that. I went and did some research and sure found out that that was true. And the gentleman I worked for then asked if we would have a hearing on older adult suicide. And I was quite amazed to find out that we weren't doing much as a nation about the problem of suicide at all, even though it was at the time the 11th leading cause of death in America. It just was not something that had reached the public policy stage at that time. That was about 1996, 1997. So having had that experience, that gentleman I worked for was Senator Harry Reid at the time, shared that he had lost his own father to suicide many years earlier and suggested we do something about the problem of suicide. And if we don't talk about it and study it and understand it, we'll never be able to reduce it. And so a lot of survivors, people who had lost loved ones, kind of wrote to the senator. I got a copy of many of those letters, and the senator said, let's do something. So to make a long story short, he introduced a resolution that called for the development of a national strategy, and also that as a nation we respond to suicide prevention, and had a response that was commensurate with the magnitude of the burden of suicide in our nation. So the rest is kind of history. We had a meeting in Nevada where lots of people came together, lost survivors, attempt survivors, policymakers, state legislators, etc., and many researchers and providers as well. And basically we came up with, what do we know about suicide? What do we not know about suicide? And the result that was the Surgeon General published the first national strategy for suicide prevention, which really gave us a roadmap on how to pursue not just treatment, but aftercare for people who lost a loved one, or reaching out to communities to help them be more responsive and making certain that any door in a community was the right door for someone struggling to get care. And that commitment has just evolved from 2001 to where we are today in 2018, with being at the point now where we've revised our national strategy, the one that you read, and it's even more refined and even more congruent with what science has taught us, and really, I think, even written with more compassion, so that it can be a tool for people in communities to find out what they can do to advance suicide prevention, and just not leave it to everyone else. But there's something each of us can do, and that was the gift, I think, of the last national strategy.
And we'll talk about that as we go along. But so, and I do want to talk about men and suicide in particular, but aside from that, what do we know about suicide that maybe we didn't know even 17 years ago? Are we any closer to figuring out, the causes? I mean, we're going to talk about something called the deaths of despair that I've been introduced to, that I have found just amazing, but also very sad. But just in general, do we know much more about suicide than we did? What is the science of suicidology, if you will, telling us now?
I think we know a few things. That first of all, in 2001, when the first national strategy was written, we really didn't have an infrastructure. States weren't prepared to address suicide. Treatment providers weren't prepared to address suicide. Many admitted they'd never been trained in assessing and managing suicide risk. So as a nation, we weren't really as competent maybe as we should have been to address the situation that was before us, which was people ending their own lives. And so I think we've trained more, we've built an infrastructure, we've got a readiness today that we didn't have 10 years ago. And at the same time, we've recognized that it's not just a mental health problem, but it's also a public health problem. There are things we can do at the societal level. There are things we can do at the community level that are just as important for making sure we have healthy communities and healthy families and healthy workplaces as making sure we have healthy individuals who may be struggling with a mental health problem. So I would say that we've learned to recognize that suicide is a health problem and not either a mental health problem or a public health problem, but we should look at it just like we look at any other illness, whether it's of the lung, of the brain, of the heart. An illness is an illness, and we need to kind of move away from any judgment we may have about a certain kind of illness and approach it in just that way, that someone we love is sick, and we need to try to help them get the resources and the access to care that they deserve, regardless of where that pain might be.
Well, and the Centers for Disease Control, the CDC, released a report, I think 2 weeks ago, or in the last 10 days anyway, that indicated, that was new information, at least to me as a layperson, that some of their research is showing that suicide is not just or even mainly a mental health issue, which was something that I had been told for quite a while, that most suicide, if you look, that about 90% of those who die by suicide have either diagnosed or undiagnosed mental illness. And the CDC report seemed to say it's a little broader than that. Right. Just maybe fill us in briefly about what that report said that was a little different.
Sure. And I think I can really share my own personal perspective. I'm a social worker by training, so I've always believed that many of the problems that individuals experience in life is somehow a problem or a challenge related to the individual and his or her environment. And sometimes environment matters. It's not just the individual who's experiencing the challenge. It may be that they have no access to care, or they're in poverty, or they're alone, or they have access to a lethal mean. There could be a whole lot of situations, or they're involved in a violent relationship or living in a violent community. All of that matters. And I think what the CDC report told us was that does need to play into our solution efforts. For example, we now have something called the National Violent Death Reporting System that's just been funded to hit every single state in the nation. And what that system does is it brings the violent death data from the states, in other words, the death rates that we know and how people died. It also ties in the law enforcement perspective and the health perspective. So we now have an idea about the circumstances surrounding a death. So we can tell, for example, whether they were involved in a violent relationship or a crisis within the last 2 weeks, whether they served in our military, whether they were under the influence of alcohol or a drug. So we have so much more information about the decedent that we can plan our prevention efforts to make sure that if it's not mental health, but it is, financial disaster or a human relationship problem with their children or their spouse, we can help in those areas and not just expect it to be something we can treat through a mental health system. So I don't think it's either or, I think it's both and is the way I kind of look at it. And I really appreciate the fact that we're going to have access to that circumstantial information that's going to really inform what we know about suicide and therefore enhance how we prevent suicide and help those people who struggle get to the right door when they struggle.
Yeah, as a layperson, not a scientist or mental health professional, I mean, I don't think I even knew that a death by suicide was reported to anybody besides, a coroner would know. But even so, the details and why that would even matter. I mean, I think my question back then would have been, well, why would that even matter? It's so personal. I mean, my son died by suicide. Why would the CDC care how he died? But what you're saying is that they actually collect that information because it helps us find ways to prevent suicide. Or if there's someone is in a situation where there's domestic violence, it helps, that information helps shape how we approach it. And so that was a piece of information I didn't used to know, and that it's now in all 50 states may not seem like a big deal to the audience, but it's actually a really big deal because it gives now complete information from all 50 states to help us design better prevention messages and methods for everybody. So let's talk just a little bit pretty specifically about men, because the statistics about men and mental illness and suicide are staggering. You and I were talking before that, we didn't want to give a whole lot of statistics, but actually I want to give a few because I don't know that people really understand the magnitude of the problem. Put on my glasses so I can see what I'm doing here. But 78%, men represent 78% of all U.S. suicides. So men attempt more often, women attempt more often than men, but men actually die by suicide. That men are 4 times more likely to die than women. That suicide is the second leading cause of death for men, 25 to 34. Another one is that men's unwillingness to acknowledge mental health problems or suicidal thoughts, coupled with the common behavior of not accessing available services, contribute to the high suicide rate for men. Men are less likely than women to access help. Is all of this fit with what you know about the statistics and the story of men and suicide?
Absolutely, Kay, and your data is spot on. I was shocked when I first realized, when I looked at the suicide deaths across America, when I saw the fact that 78% of completed suicides were men. I stepped back and just said, my goodness, that's a pretty significant proportion of males to females that die by suicide, and females attempt more and use less lethal means. So again, if you're thinking about public health, this opens up the conversation about if men are choosing more lethal means, there's less opportunity to save them or to introduce, and I love this discussion, to introduce time and space between thought and action. Sometimes if you can just separate a person who's having suicidal thoughts from a lethal means to take their life, that hour of separation or time that you give them can be a life-saving hour. So it's why it's so important that we talk about access to overdoses of medication or lethal means or whatever the case may be, poisons, so that we can save lives and reduce the lethality if someone is attempting to take their life, so that we can help them through the moment and get into care. But it's true, and we're seeing in the nation the highest increases in suicide seem to be amongst those in the middle years of life, both men and women. When I first started out, I know with my own doctoral dissertation, I was most interested at the time in older adult deaths and older adult males, white males in particular, who had the highest rate of suicide in the nation. So I kind of got pulled into that male reality quickly and have been trying ever since to better understand what we can do to reach men, understanding they're a very different population with a very different social and cultural exposure that we have to be mindful of.
And I want to talk about that. I want to just step backwards to when you were talking about lethal means. And that can be a controversial subject, and yet it really doesn't have to be, because it is factual that in the United States, more men, or I think it's like 51% of suicides are by gun, death through a gun. And then I think the second is through hanging. And I know this is really graphic, and I apologize in one sense, but on the other hand, we have to have some of these hard conversations, because as Dr. Reed said, that if you're a gun owner, lock them up. Make sure that your guns are very safe, are secured, that the ammunition and the gun are not in the same place, that your children and your students, your children, your teenagers don't know that code, so that they can't access that in a moment of despair or in a moment of agony, mental agony. When people talk to me about their suicidal loved ones and how worried they are, one of the first questions I'll ask is, does your loved one have access to lethal means? And if they say yes, I say, then you must remove those lethal means from your home. Or if your loved one refuses to do that, then they need to be locked. I mean, you have to take that seriously. And all the efforts, I know that even in the Action Alliance around with gun shops, in teaching, gun safety, in places like where people are shooting ranges and gun shops. So I can't overemphasize how important it is, as you said, to put a little bit of time and space between someone's thoughts of suicide and their pain of thinking that they need to leave, they need to get out of here, and to not have access to lethal means. That in itself can let that moment pass. Yes. And someone will actually go on to live, find the help that they need, and they're so grateful that they did not have that access. In that, survivors of suicide attempts tell the story that they're glad that they did not actually die by suicide.
That's absolutely right, Kay. And the other fact that I think is really important for your listeners is that science does tell us that most people make the decision to act on their suicidal thoughts in an hour before their death. So that time is vitally important. And if the temptation or the access to a lethal mean is removed from the equation, we find that after that hour passes or that short time passes, the crisis de-escalates and we have our loved one to help.
They go on to live. Absolutely. And then you were talking, going back to what you were saying about how men access mental health care differently. As a woman, I mean, this may seem so obvious, but it actually has taken me a while to realize that men and women respond to mental illness and in the ways that they seek help and treatment very, very differently. You can tell a woman, hey, come to a support group tonight and share with this group. Maybe you're feeling, depressed, you're feeling, you're struggling with anxiety. And you sit in this circle with these other women and talk about how hard it is and how much you're hurting. And women will go, yeah, I'll be there. I'll be there. And you tell that to most men. And it's no secret that most of those kinds of support groups are populated by women, not men. And it actually took me a while to realize that might not be the best strategy to talk to a man. So what would you say are some things that we know that make a difference for men and women in even accessing the help for mental illness or suicide prevention?
Yeah, I think men and women do seek help differently. I mean, it's very difficult to generalize, but I know if it weren't for my wife saying you have to go to the doctor, I probably wouldn't see that as my first choice. So I'm grateful to have her advice when it's time to go and have something checked out. And the older I get, the more a believer I become in seeking healthcare. I think it makes a lot of sense. But
That's called wisdom. That's called wisdom.
But I think even socially, men and women are exposed to healthcare very differently. Women, almost by design, caring for children and seeing the pediatrician, and for their own health, kind of healthcare seeking is a regular part of that life routine. Whereas for men, it's when we're on the last breath, that in many cases that we're willing to go and tell someone about our pain. Because for some reason, we just have never been acculturated to behave that way. I think it's changing. I think for many men, I think we have to change our paradigm, for example. I think men will respond to other men probably more openly and willingly than they would to a male-female group. Men men think sometimes, and I can only say this about me as a male, but others I'm sure have said this to me many, many times. I don't want to take a space that someone might need more than I do. So men tend to minimize the need for help because someone else may need it more than them. And I think the other part of that sometimes that you find is that, men are willing to get help, but they want to give something in return. They just don't want to receive a gesture. For them, if they can balance that receipt from giving a gesture, then it makes it more legitimate. So we have to find ways, I think, for peers to reach out to other peers, for men to reach out to other men. And I know you and I have talked about this, and when I came to Saddleback some time ago, I just saw this as clear as a bell. Ministries, ministries for men's health just makes such incredible sense to me. If a man in a community where a house of worship is present stops coming to service because his wife passed away, or he stops coming to service or whatever because he's ill, I mean, they will not come back once they step away, or once, their partner who encouraged them to come to service is gone. We have to be mindful that's probably an opportunity to outreach and bring them back to the community that cares for them.
That moment that is a great comment. I had not actually thought of that. I thought of it more in terms of I thought of men reaching men talking to men talking to men on the level that another man's going to respond to. The idea that it's not weak to ask for help in any area. Men are notorious about. What are all the jokes about men not stopping for, not even asking for directions because they're pretty sure that they know how to get where they're going. And sometimes that I've noticed that a few times in my life with a few of the men in my life. But the point is that if we're not, as you said, culturally acceptable for a man to ask for, even if it's directions, let alone talk about the physical symptoms he's having or the emotional pain or distress that he's feeling. So how men can reach men. And that makes me think of, there's a group in Colorado called, they call it Man Therapy.
Yep.
And it's one of those sites that I would really like to recommend to anybody who's watching. It's mantherapy.org. And it was a collaboration between a public relations firm and I think the Colorado either suicide prevention team or something. I mean, it's some pretty good people have put it together, and it's framed in such a way that a man is going to watch it. It's got some humor that I'm, a little uncomfortable with, to say the least sometimes. But it really talks to men through the lens of a man rather than through the lens of a woman. And it feels like it sets up a model for guys to be able to say, look, it's so cool to get help. And as you said, Jerry, don't wait until you're gasping on that last breath before you reach out and ask for help. What else have you found, or have you found anything? And I also love the idea of talking about the faith community, because as you said, this is something that every faith community can do. You don't have to have a cool website like Man Therapy, but just that idea of community and caring for each other and being plugged into a faith community, this is something that's within the reach of all of us. This is not just for a big church like Saddleback, but that caring community that notices maybe a widower, who is no longer coming, or a man whose wife has a chronic illness and they're not showing up as much, and just really reaching out to care for them as a whole person.
No, I think so too, Kay. And I would also say that, we lose some of our men and women who serve in battle, but men who have served come home broken sometimes, not all the time, but some do come back carrying a heavy load. And we found that veterans helping veterans is a really wonderful way, because there's a language, there's a culture, there's a respect for one another's walk and talk that matters when you're trying to encourage someone to seek help. And you have the courage to say, I've known you for a long time, and I can just tell there's something on your mind. And sometimes when people retract like that, it might mean that they're struggling in silence. And I care enough about you that I want you to feel comfortable. You can talk to me. And
well, you mentioned. Sorry, go ahead.
And I was just saying, and be there for your friend. And I would just want to reinforce for our spouses, I can't tell you how important it is for the women in the audience. If the man you love, or the son you have, or the male relative that you have is not the person that you know them to be, please have the confidence with care and love to say, look, I'll go with you, or you really should talk to somebody, because we do listen. We do listen to the women in our lives who make suggestions like that. And I think that's also a really important part of the help seeking.
That's a great idea. I was thinking of the veterans that you mentioned, Celebrate Recovery. We've talked about this before in some of the Facebook Lives, but Celebrate Recovery, celebraterecovery.com has some groups called Welcome Home groups, and they are specifically for veterans, those who've seen combat duty and those who haven't, but who maybe are on home leave, or maybe they've left the military and they just are missing pretty desperately that sense of camaraderie, shared purpose. And Celebrate Recovery Welcome Home groups are a great place for people to talk about their hurts, their habits, and their hangups. And we'll pin that in the Facebook Live, so you can go back to celebraterecovery.com and found that. So if we were wrapping up, there's just one other thing it's kind of technical, but was really dramatic for me was when I heard about something that social scientists, I think, are calling deaths of despair. And deaths of despair, I want you to explain that to us in lay terms, if you would, because you can tell us all the really good stuff, but in terms that would really make a difference to our audience, to understand why this is important and why this is statistically affecting the mortality rate for men in a certain group.
And to be truthful, Kay, I'm much more comfortable with the lay-term stuff.
Oh, good.
Even though I've been through the empirical stuff, my neighborhood is the lay-term stuff. So I'm intrigued by deaths of despair as a concept and a way to understand what might be happening to men in our country. And I've looked into it. I'm familiar with the research of Sir Angus Deaton and Dr. Ann Case from Princeton. And basically what they found by looking at data is that we've seen a decrease in life expectancy in the United States, which is a most unusual decrease, usually because of better health and access to health, et cetera, and better science, the life expectancy increases. Well, that's not been the case in the last 2 years. And when they dug a little bit deeper into the data, what they found was that 3 types of deaths seemed to explain the decrease in life expectancy. And they were suicides amongst men, they were alcohol-related cirrhosis around men, and they were opioid overdoses. And they looked at the data for both men and women. And so deaths of despair kind of are that tripling, if you will, of suicide deaths, opioid deaths, and alcohol-related cirrhosis deaths that seem to be happening in certain pockets of the country. And when you look a little further, they are pockets where opportunity seems to not be as available as it is in other places in the country. So,
and you mean by opportunity? What do you mean by that?
Working. So economic opportunities. And so having a job, in a mine or a mill or a factory plant where generational jobs were available generation after generation have gone away because technology's improved or jobs have moved elsewhere because the factory has moved or the mines have closed because they're depleted. And the people who have remained, unfortunately, many of them in the deaths of despair conversation, those with a high school education or less tend not to have find opportunity, and therefore try to ease their pain through self-medication, either through substances, alcohol, or maybe they're so in pain that they don't think this is going to pass and they end their life to suicide. So we have to think hard about going back into these communities, presenting opportunity to people, helping them find purpose in their life, and either maybe even through the many houses of worship, for example, or the Veterans for Foreign War, the Disabled American Veterans, or whatever employers that are there. Just be more mindful that there's a group of people now sitting in desolate places that are beautiful but don't have opportunity for them to make a living, to contribute to the life that we have in this country, and to feel like their life has purpose. And what happens oftentimes is they might have an encounter with the law. They might, because they can't provide for their family, feel like it's not worth living. Their life is not worth living. Or they may even, because of their visiting the bar or whatever the case may be, their wife may say, I can't take this anymore. And so she'll end the relationship. So one bad situation becomes many bad situations. And I think that may be contributing to what you're referring to, and certainly what I know to be deaths of despair. So I think it just makes the argument that this really is far more than just a mental health challenge. We have to find ways to bring opportunity back to communities where that opportunity is going away. And I think we can do it. I think we're smart. We want to build an infrastructure in America. We want to strengthen our bridges and our roads. Well, let's look to the people in the communities that have the skills and are looking for the work to help us do that. As we talk about retraining, let's really look at helping people retrain for jobs of the future. That's suicide prevention, even though we might not think of it as suicide prevention. And we know there's an opioid crisis. We know there's a rise in suicide deaths. So I think our solutions to what we're witnessing have to be creative and innovative and kind of be informed by things like the deaths of despair conversation that we're having. And how can we maybe help these communities get stronger and feel better, and make the men in these communities feel like they're vibrant and contributing in a way that they once felt they were.
It's such a complicated conversation. There are a lot of complicated conversations, in our country right now, and I feel like this is one of them. And when I had read that study, I was really taken by one of the other factors. There was the economic factor that you mentioned that seemed undeniable, had an impact on the deaths of despair, but also that people have stopped in that area, in that particular part of the country, are maybe not as highly participatory in organized religion as they were. And that we know that being part of a community is a protective factor. So if people are experiencing economic difficulties, and then maybe they've lapsed in their church attendance or synagogue attendance, and also that the divorce rate, that was also perhaps a factor, that people didn't have that strong connection in marriage. And you combine all of that, and then with the higher availability of opioids, it just feels like it's this very toxic mix for particularly men in a part of our country that, as you said, have been hard hit by some economic realities. Anyway, it's sad because it's not just, oh, wow, that's sad. No, it's actually changing the number of people who are dying. And that's beginning to affect a national average. And that is something, it's not just a little thing right here. It's significant. But you mentioned several things about how we can start to make some differences. So as we close this, what are some things that the average person can do to, if you know somebody that if you're worried about them, how can an individual person make a difference in the life of somebody who is struggling with suicidal thoughts or feelings?
Kay, I think about this every day, and there are some good answers to that. And the last couple of weeks when we've seen some prominent suicide deaths, tragically, and we've certainly seen the CDC report and have recently released veterans report about some suicide deaths in that community, I try to think about what is it that if I was talking to my neighbor or my grandmother or whomever, I could kind of share that would mean something to them, so I don't just rattle off a list of warning signs and things like that. And I'm kind of thinking hard about, to me, there's a universal risk factor that we should be mindful of, no matter who we are or where we are, and that's isolation. Isolation is a risk factor, whether it's psychic isolation or spiritual isolation or emotional isolation or physical isolation. Isolation is a risk factor for struggle. Yes. And on the other side of the coin is the protective factor. And to me, the universal protective factor is connection. Whether it's psychic connection or spiritual connection or physical connection or emotional connection. And so the simplest thing I could say to your audience is, be mindful of people who may be isolated and the value of what your connection can bring to them. That's a simple thing that we can all remember every single day. But I would also say, don't be afraid to ask somebody if they're thinking of taking their life or if they're thinking of ending their life, because you will not put that idea in their head. If anything, you will give them a sigh of relief and an opportunity to embrace your invitation by being honest with you and having you guide them to help, wherever that help might be. So asking people honestly if they're thinking about suicide is a very fair question, and not one that's going to in any way compromise their value or their belief in you. They'll be grateful. I also think, don't think that a struggle that you witness today will be over tomorrow all by itself.
That's good.
If someone is not the person they were last week or the week before or the week before, inquire about it, because it's generally a sign that something's going wrong. And most people who end their life either give warning of that through behavior or through words. So pay attention when you hear that. I don't want to encourage your viewers to be, on edge every moment with every comment, but I do think compassion and connection and love are, and that's not very scientific of me, and I realize that, but I think compassion, connection, and love are very much a part of what we need to do, coupled with the incredible brilliance that science gives us. And when we bring those together as a nation or as a world, we're going to save a lot of lives.
Thank you. That is what a perfect way to end this conversation, because there's a role for science and there's a role for each of us as human beings to care for each other, and to, as you said, compassion and care and communication and connection. Thank you, Dr. Reed. Thank you so much.
Thank you, Kay.
Appreciate all that you do and look forward to seeing you again soon.
Thank you.